A few months ago, Nina Sharial talked with Amy Pruitt about the highest grade glial tumor of the central nervous system, glioblastoma.
The median survival is 12 to 14 months, with less than 10% of patients surviving 2 years from time of diagnosis. Despite these striking statistics,
it's a universally fatal disease, so it makes all too much sense to be as aggressive as possible in treating patients with this type of primary brain tumor. But what about the lower grade glial tumors? What should we do about them? In this week's episode of the Brainwaves podcast, we'll cover what these tumors are, and why or why not you might want to be aggressive with these patients as well. Don't go anywhere.
Support for this episode of Brainwaves and the following message was brought to you by Audible, which you can access so easily from your smartphone or computer. You can use it while you're in the kitchen, while you're at the gym, or while you're driving. And there are so many great books to choose from. So after you're done with this episode, go to audibletrial.com/brainwaves and enjoy a free month and a free audiobook of your choice. But enjoy this episode first, then Audible.
This week, I'm joined by Dr. Brian Nahed.
I'm a neurosurgeon at Mass General, and I specialize in brain tumors.
And also, we've got Dr. Jorg Dietrich on the line.
I'm a neuro-oncologist at Mass General Hospital and also physician-scientist working in that field for approximately 20 years.
Who both joined me via Skype. Hi, nice to meet you guys. Thanks for doing this. The purpose of today's talk was to get their insight into low-grade glial neoplasms, non-malignant primary brain tumors. In 2017, we had Amy Pruitt discuss the 2016 updates to the WHO classification of CNS tumors, and she spoke a lot about how this impacts the diagnosis of a grade 4 glial tumor, glioblastoma. But what does this have to do with lower-grade gliomas?
It's been an exciting time in the world of brain tumors from a diagnostic as well as a sort of a predictive side. The WHO has given a lot of credence to the fact that, and now when we talk about tumors, we no longer talk about them just on histologic grade, but rather by their molecular and genetic characteristics.
Yeah, I think the key features is that with a more accurate diagnosis, we will have a much more fine-grained information on prognosis and also on a predictive value in terms of therapies.
Before 2016, the classification of gliomas was based entirely on their histological appearance, as Dr. Nahed mentioned. But new breakthroughs in molecular diagnostics have dramatically changed the way that we prognosticate tumors of similar histology, but differing molecular properties.
The layered approach of the new classification system from 2016, which essentially is an update from the 2007 system, uses, as Dr. Nahed pointed out, both histopathological and genetic molecular information to an integrative diagnosis,
giving us a good fingerprint or an explanation to the different categories of tumors,
which has informed the community of oncologists and neuro-oncologists to a large degree of why certain patients might do better than others. For instance, if now molecular features such as IDH mutation status or 1p19q co-deletion status are acknowledged, this has allowed to reclassify certain entities that have been at the borderline of leading to a lot of confusion in the field, such as oligoastrocytomas, that had been characterized by a very large and significant inter-investigator discrepancies. So some of investigators have called out on these tumors to be more astrocytic and others more oligodendroglia-like. And now I think with the help of molecular genetic features, we are much more able to put them in appropriate categories and hence have better stratifications for treatment and beyond that for clinical trials.
And while this information has provided us with considerable insight into the natural history of these tumors and their response to treatment, not all centers have the technology for genotyping and molecular diagnosis.
Low-grade tumors traditionally have been WHO grade 2 type of tumors, with the grade 3 type tumors taking an intermediate role and being more classified as high-grade tumors. So a low-grade tumor classically would have been a WHO grade 2 tumor in the adult world, and grade 1 type of tumors are more commonly encountered in children.
Among brain tumors, recall that metastases are by far the most common tumor in adults. Excluding metastases, meningiomas are the most common primary CNS tumor. Low-grade gliomas are a bit further down the chain when it comes to overall incidence, with fewer than 1 in 100,000 new diagnoses each year. Most patients present in their 20s to 40s with clinical seizures, or they're identified incidentally on other brain imaging. And more often than not, their first referral is to a neurosurgeon.
There's two major roles a surgeon plays in this. One is for the actual diagnosis of the tumor, and two is to maximally and safely resect as much of the tumor as possible from an oncologic perspective. The first, for a diagnosis, they'll look very similar to what we historically will call low-grade gliomas.
Meaning on MRI, they appear as non-enhancing, non-restrictive lesions with bright signal on the FLAIR or T2.
Yet we still need the tissue diagnosis for it. And so, as a surgeon, our goal is to not only provide the diagnosis, but to safely remove as much as possible. When I look at an MRI of a patient, the first thing we tend to look at is whether or not it's an eloquent cortex, meaning somewhere around language or motor function, and any possible deficits, and whether or not it would make sense from a preoperative workup to do further imaging like a functional MRI or diffusion tractography. Once you come to that conclusion that you're going to move forward and you have a good avenue to do it, the goal really is to try to remove as much, if not all, as safely possible. And when we say safely, we really mean maximizing the extent of resection, the removal of the tumor, but also trying to do it in a way that leaves the patient with no deficits.
Surgical debulking is almost never questioned when there's significant mass effect, or if the patient has neurological deficits. But the surgical management of incidentally identified tumors, or tumors which present with mild, infrequent seizures, is less clear. There's limited high-grade evidence that surgery is beneficial for the average patient with a low-grade glioma. However, like Dr. Nayat said, it is important for neurologic diagnosis, unless the tumor lies within eloquent cortex. Regarding resection of probable lower-grade tumors found on MRI, one large series of 216 patients demonstrated that removal of more than 90% of the tumor bed increased 5-year survival from 76% to 97%. Similar numbers were observed from a cohort out of Johns Hopkins with maximal debulking. But additional resection doesn't come without its own consequences. Here's Dr. Dietrich.
And treatment has been much less homogeneous across the field in terms of what modalities are to be used to manage these patients other than surgery. So I think surgery always had a very clear role, but radiation or chemotherapy have not.
But the gains we've made in the care of our patients is not wholly attributed to surgery. I feel like there's been a shift towards using earlier adjuvant therapies like radiation and chemo for lower grade tumors. Can you describe how this shift happened?
So recent years have seen a number of clinical trials that were reported using data that accumulated over essentially the past 15, 20 years, which has suggested that patients who were diagnosed back in the late 90s with so-called low-grade gliomas did fare better and overall had an improved survival when adjuvant radiation was combined with chemotherapy. In contrary, I think if a patient is of so-called less risky features of young age and had a gross total resection and the tumor overall has fairly benign features, then I think a watchful surveillance is still an acceptable approach. But any patient with more higher risk features such as residual disease or older age would nowadays be recommended to have adjuvant therapy with radiation at minimum. And I think based on the newest clinical trials, in particular the RTOG 9802 chemotherapy regimen with a PCV treatment, which is procarbazine, CCNU, and vincristine, might be of benefit in a subset of these patients.
The RTG089802 was a Phase 3 randomized clinical trial of adult patients with WHO Grade 2 gliomas who had previously undergone debulking surgery. Patients were randomized to radiation therapy alone or radiation followed by 6 cycles of adjuvant PCV. Overall survival and progression-free survival were roughly the same at about 2 years. However, after 2 years, the survival curves diverged, and patients who received chemotherapy following radiation were more likely to live longer, and to live longer without disease.
There is still a controversial debate about whether alternate regimens such as temozolomide would fare equally well in this setting in patients treated with surgery and adjuvant radiation followed by this particular chemotherapy. But a head-to-head trial has never been done. And so I think there is some discordance on how patients are managed, I think, overall across the United States and between the US and Europe.
Say they have recurrence. What happens then as far as surgical and non-surgical management?
So it's a great question, and we see patients all the time who have received some type of therapy, and not always the same therapy, particularly as this field is changing so rapidly. Whenever I see somebody in the clinic, the first thing we do is look at their not only their initial scan, but their post-operative scan, their post-therapy scan, and then now their new presentation of recurrence. If somebody's had radiation, one of the things to always be aware of is the possibility of some type of treatment effect or radiation effect versus just true recurrence. So, we tend to do everything as a group, and we'll review these at our tumor board, or at least with a neuro-oncologist as well as myself. If it's a number of years or even longer from the initial diagnosis and therapy and the patient's undergone treatment, sometimes, depending if there's a large mass, the goal will be just to remove the mass and to get more molecular and genetic data to recharacterize the tumor. And so, as you can imagine, that tumor may have a different classification or characterization several years later. And the role of surgery, again, would be for diagnosis and to remove as much of the recurrence as possible.
In general, I think if patients have been under surveillance for a number of years, then going back to a similar regimen is always a consideration. So if you have a patient, for instance, treated for an oligodendroglioma about 8-9 years ago, and now there's recurrent disease, you might consider to go back to a similar chemotherapy. Others prefer to choose a novel regimen. So if this patient were treated, for instance, with temozolomide 8-9 years ago, you could now consider, based on the novel data, to use that PCV regimen, or even re-exposure to temozolomide is a consideration. So this depends a little bit on
The alkylating agent temozolomide has not been studied head-to-head against regimens like PCV for lower-grade glial neoplasms, but that doesn't mean that it's any less effective. Temozolomide is an older agent with known efficacy in low-grade and high-grade glial tumors for both overall survival and progression-free survival. Unlike PCV, temozolomide is easily administered because it comes in oral and IV formulations. It has a better tolerability profile, and it's more available in some regions of the world. And for your more aggressive gliomas, sometimes we turn to the VEGF inhibitor bevacizumab.
Recurrent disease, however, the tumor would, on imaging and perhaps clinically, would have to have a much more aggressive phenotype, such as with profound contrast enhancement, a lot of cerebral edema, perhaps shift of the brain, and resulting in severe neurological deficits. In these patients, you would certainly consider a powerful infusion drug such as bevacizumab.
Dr. Nahed, what do we have to look forward to as far as future trials for low-grade gliomas?
Well, we started the call talking about the WHO criteria, and I think now as we're getting more and more sophisticated and classifying these tumors, I suspect that not only those who will benefit from surgery, but those who will benefit from different types of therapy will be a lot more evident. As Dr. Dietrich was pointing out, things as basic as, do I give someone temozolomide or PCV? There might be a subset that respond to one or the other. Similarly, I think surgically, we hope to continue to advance doing safer and more aggressive surgical resection using intraoperative mapping and using techniques to take out tumors that historically had been considered difficult to take out or inoperable. And I think as surgeons, you look at some of that data that says that if you can get a gross total resection in a young patient, you could potentially surveil that patient. That, to me, is a significant support in saying, as a surgeon, you really should try to get as much out in the first time as you can, as safely as possible. And I'd love to see both surgical and medical trials and continue to advance our field. And I would also just end with, I think diagnostics will be an important, as the field of liquid biopsy starts to catch fire, and there's a lot of attention as to can we find some of these molecular markers or genetic characteristics through the blood. I hope that will play a part in the role of the management of these patients.
In addition to chemotherapy and radiation, patients are often offered supportive care. Treatment of vasogenic edema typically consists of high-dose dexamethasone followed by a slow taper. Seizures are often controlled with single or multiple antiepileptic therapies, but surgical debulking is also thought to be effective here. Headaches, fatigue, and cognitive impairment are also not uncommon complications to this disease, and these symptoms are managed supportively.
I want to kind of emphasize that there is a significant need to develop clinical trials for patients with low-grade tumors. While you may say, well, they have overall a much better prognosis and outcome than patients with higher-grade tumors, the landscape really of clinical trial development has been dominated by development for glioblastoma or high-grade type of tumors. And so I would estimate that approximately 90% of the clinical trial landscape is really only eligible for patients with high-grade type of tumors and glioblastoma, whereas the kind of availability of clinical trials for lower-grade tumors is much less prominent. That said, however, I think there is a huge opportunity because we are talking about a patient population that might benefit tremendously from even a minor alteration in the overall trajectory. If you have an outlook of survival of perhaps 10 to 12 years, and you could shift this to the 20 to 25 year range because of molecular informed or genetically informed targeted therapy, this would be a tremendous success of turning a disease into perhaps a chronic condition. And I will just name one prominent representative, which is the IDH targeted therapies. The majority of low-grade gliomas are IDH mutant. And so I think here you have a very specific target that is not evident in normal tissue. And if I think the science advances for us to target these particular alterations more sophisticated, then I think we will make a bigger difference in the future lives of these patients.
Regardless of the initial treatment, the natural history of gliomas is to continue growing, and most will recur, or transform into a higher grade neoplasm. So it's a bit of a misnomer to think that just because gliomas are low grade, it doesn't necessarily mean they're benign.
This is a disease that comes in different forms and phases and can at any given time take on a different shape. And so I think you treat it in a different manner if you avoid these terms, I think, and also discuss this appropriately with your patients, that this is a disease that can progress at any time and even then switch to a more aggressive phenotype.
But as we discussed today, there are more effective therapies now than ever before. Combining more advanced surgical techniques and implementing intraoperative MRI, as Dr. Nahed does at Mass General, and utilizing adjuvant radiation and chemotherapy with PCV or alkylating agents has dramatically increased survival in these patients. And not just survival, but survival without disability.
When I started in this field 20 years ago, we had very little to offer other than surgery, which was the main treatment. Perhaps radiation and chemotherapy options were frowned upon, including CCNU or BCNU. We knew they were active, but they were just also associated with a lot of toxicity. And I think having now hundreds of compounds in the pipeline and more information about each individual tumor patient is reason for hope. And I think in patients who are treated now, they may actually, with the current pace of development, witness some major breakthroughs in years to come while they are still candidates for treatment with these novel discoveries.
In the 1980s, the average survival for patients with gliomas after surgery and radiation was about 7 years, with survival from the time of recurrence being about 12 months. If you extrapolate the 2012 data from the RTOG 9802 trial, The projected survival for adult patients who undergo combination surgery, radiation, and chemotherapy with PCV increases from 7 years to more than 10 or 12 years, almost doubling one's life expectancy. It's a really exciting time to be a part of this change, and there are even more options in the pipeline that we have to look forward to, so stay tuned. Special thanks to Drs. Brian Nahed and Jorg Dietrich for joining me on the show this week. For more information on what we discussed and a glioma diagnostic flowchart, take a look at our blog entry at brainwaves.me. The episode this week was supported in part by Audible, where you can choose from hundreds of thousands of books you'd never be able to read because you're too busy running around the hospital. But in your free time, you can listen to one, completely free, by signing up at audibletrial.com/brainwaves. The Brainwaves podcast is produced out of Philadelphia, Pennsylvania. Jim Siegler, senior producer. Voiceover by Erica Mejia and commentary by Drs. Brian Nahed and Jorg Dietrich. Music for our program was courtesy of Ian Sutherland, Lavira, and Lee Rosevear. I'm Jim Siegler. Thanks for listening.